Good day once again. And now we go to Module 3 to discuss the steps in contact tracing at the local government level. Please take note, in conducting contact tracing, we should only do it in our area of jurisdiction. Province will oversee the cities or the municipalities, and beyond that, it is the Epidemiology Bureau of the Department of Health. In between countries, the World Health Organization has the power to oversee. In public health, the process of contact tracing is not anything new. This process includes the identification of persons who may have into contact with an infected person and subsequent collection of further information about these contacts. By tracing the contacts of uninfected individuals, testing them for infection, treating the infected and tracing their contacts in turn, public health aims to reduce infections in the population. So what are the goals of contact tracing? First, we need to interrupt ongoing transmission and reduce the spread of the disease. One way of interrupting transmission is identifying the infected person and the people exposed to him or to her. We have to quarantine him or her to avoid people getting close and to avoid additional contacts. The other one is we need to alert the contacts of the infected person about the possibility of infections and offer preventive counseling or prophylactic care. That is our work as public health officers. The third goal is we offer diagnosis. If a person tested positive for COVID-19, we provide them with counseling and treatment. In counseling, we will take him or her either to quarantine facilities or isolation facilities, which are both referral facilities. Earlier, at the start of the outbreak, the WHO had already said that there was a possibility of reinfection of a patient that experienced COVID-19 before. That's why we refer to the new normal, because it is not a one-time immunity. Current data showed the existence of different COVID-19 strains. Lastly, the lessons learned. We have learned about the demographic and time place of the person. It means the demographic of the disease of COVID-19, the whole range of spectrum, what the presentation of COVID-19 is, and what is a good treatment and management of COVID-19 cases in the hospitals as well in the community. We write that up so that when COVID-19 returns, we already know how we will fight it. Endemic diseases are infectious diseases that are already there. There are other endemic diseases that are less capable of having an epidemic. We do contact tracing so that we can see again why there are unusual outbreaks. The Philippine Integrated Disease Surveillance and Response, operationalized by the Epidemiology Bureau and the Regional Epidemiology and Surveillance Unit or the RESU level, is the bureau assigned there. There are 24 diseases and syndromes added apparently after 2009 and is being monitored. One of those endemic we see is meningococcemia. We are investigating that particularly in Baguio City where there was an outbreak. Endemic diseases are those that can be contagious like measles, chickenpox, and tuberculosis. We also have contact tracing on tuberculosis. Contact tracing is also used if we have a probable case. When we do contact tracing, and if there is a secondary transmission going on in the community, you have to inform immediately the rightful agency that will handle the case, especially the Department of Health. Example, supposing I return to our province and this province has no case of COVID-19, and I came from an area with local transmission, and I didn't observe the 14-day quarantine and have the virus, and possibly infected my brothers or my sister. If I infected my brother or my sister, it is secondary transmission. In this case, it is first generation, because I came home and I brought the virus. If I have infected anyone and have transmitted the infection, it is called a second generation infection. If I infected my brother, there was a secondary transmission that can be transmitted to everyone. We will find in contact tracing if my brother or my sister infected his or her co-worker. His co-worker is called the third generation. If my brother's co-worker also infected his brother or sister or a family member, this is in the 4th generation. 4 translation already. Beyond 4th generation, it is quite difficult for us to contact that. That is what we call localized transmission or community transmission. The secondary transmission is if I am the index or the 1st generation and I go home to a place where there is no case and I pass it on to someone who has no history of travel. If we did a contact trace and got infected to a certain person, I had a secondary transmission to that. This is also initiated among flight passengers during the containment phase of the pandemic. It started from 2 foreign tourists who traveled around the Philippines. Their combined close contacts are approximately 1,500 individuals. Now that the local flights here have returned, the contact trace of local and international flights will return as well. Who is now the contact that we will identify? It is the person suspected with COVID-19 virus. He or she should be asked about his or her activities, his or her roles, who she came to contact with since the onset and 2 days before the onset of the illness. That is what we are looking for. Who is the contact? As what I've said earlier, it can be family members, colleagues, friends, healthcare providers, and the community. If he or she does not observe community quarantine, the one he or she encounters on his or her whereabouts will be subject to become a suspect. The second basic step in contact tracing is the contact listing or profiling. We consider that all persons that have contact with the infected person should be listed as contacts. Identify every contact, their name, middle initial, surname, and contact numbers. These are all very important. All identified and listed contacts need to be informed of their contact status. Explain to them what activities or actions that will follow so that they be given assistance. Once they have been identified as close contacts, they should be taken to quarantine or isolation areas. The last basic step in contact tracing is contact follow-up. Steps 1 and 2 are useless without doing regular follow-ups. Because here, we will know already that some of the close contacts are infected. How many of them are infected? All individuals that we have identified as close contacts will be monitored for possible symptoms for the next 14 days after the last exposure. In some cases, quarantine or isolation is required for close contacts either at home or in hospital. Normally, close contacts are quarantined in isolation facilities within their community. Who is the COVID-19 case now? The use of Form A or the case investigation form for COVID-19 is the case definition of the probable suspect who was confirmed of COVID-19 cases. Who is the suspect for COVID-19 case? This is a person who has any of the following conditions. One is SARI. SARI is a severe acute respiratory infection surveillance. This case is being admitted to selected hospitals because surveillance is expensive. ILI cases or influenza-like illnesses are seen mostly in the community. This is reported under the PhilHealth Services Information System with the same pixels. These ILI cases have been reported by consultants in rural or city health units throughout the country. All SARI cases where no other etiology fully explained the clinical presentation. This means that this has been examined by a doctor in the hospital. If the entire laboratory results did not show the cause of the disease or can no longer be identified, then it will be a COVID-19 suspect case. Second is with contact to a confirmed or probable case of COVID-19 2 days prior to onset of illness of the said COVID-19 case until the time it became negative on repeat testing. And third, individuals with fever, cough, shortness of breath, or other respiratory signs and symptoms fulfilling any of the following: age 60 years and above, with comorbidity, assessed as having a high-risk pregnancy, and healthcare workers. This case investigation form is not self-administered and should be administered by a trained surveillance officer. The surveillance team is encouraged to conduct this case investigation. That was the problem of the DOH when the case flooded in NCR, Calabarzon, and other regions. If the form was given to the patients and they did not fill it out completely, it might be our problem as contact tracers. For example, on the form, if they do not fill out the address, we might not be able to trace them. Same with their contact numbers. If this happens, it will defeat the purpose of our response as contact tracers. The probable case is a suspect case who fulfills any one of the following: suspect case whom testing for COVID-19 is inconclusive. Suspect who tested positive for COVID-19 but whose test was not conducted in a national or subnational reference laboratory or officially accredited laboratory for COVID-19 confirmatory testing. And suspect case who died without undergoing any confirmatory testing. A confirmed case is any individual, irrespective of presence or absence of clinical signs and symptoms, who was laboratory confirmed for COVID-19 in a test conducted at the national and subnational reference laboratory and or DOH certified laboratory testing facility. If you are not trained as contact tracers, you will forward it to the surveillance officer. The DOH has a basic course on contact tracing that teaches how to fill out a response. Who is a contact of COVID-19 case? The close contact categories and definitions are based on the DOH guidelines. Category A applies to an individual whose seat is located 4 rows in front, back, or any side of a confirmed case in a plane or sea vessel, bus, train, or other transportation or vehicle who is still in the Philippines. Category B is just the same as Category A. The difference is that the suspect of COVID-19 is no longer in the Philippines. The Philippine Epidemiologist Bureau will coordinate with that country's point person bureau. The director will then coordinate it with the WHO to find the suspected COVID-19 case. Category C includes persons who have had exposure with a confirmed COVID-19 case. World Health Organization has recommended that this will include individuals who have a face-to-face contact for at least 15 minutes while within the 1 meter prescribed distance or have shared an enclosed space for a minimum of 2 hours. This means, for example, if the bus or van is air-conditioned and you were together for more than 2 hours, you will probably be a close contact. The Category D includes passengers or crew of vehicles or vessels taken or used by and persons who lived, worked, intersected with, or cared for a suspect who died during their 14-day monitoring period. What is the difference between isolation and quarantine? Quarantine is used by the government to stop the spread of contagious disease. We have an infectious disease law of 1929 with a penalty of 100 pesos. However, it was repealed by RA 11332, which became law last April 26, 2019. The current IRR was enhanced last August 2019 for people or groups who don't have symptoms but were exposed to a positive case or to an identified probable case, keeping people away from others so they don't unknowingly infect anyone. Isolation, on the other hand, has the same principle of quarantine. Isolation facility is reserved only to those who are already infected by the disease. It keeps the infected away from healthy people to prevent the sickness from spreading. Isolation is for the sick people, while quarantine is for those people who have an exposure but who are not sick. In a nutshell, both quarantine and isolation prevents exposure to people who have or may have a contagious disease. Isolation separates sick people with a contagious disease from those who are not sick, while quarantine separates and restricts the movement of people exposed to a contagious disease. They are under monitoring for 14 days. That ends my presentation. Thank you very much.